This morning we're going to be having our annual talk on bloodborne pathogens annual review. We have Dr. Louise Dembry and Dr. Mark Russi who will be presenting. Dr. Dembry is a graduate of Wayne State University School of Medicine, which is also where she did her residency in internal medicine and infectious disease fellowship. She came to Yale after her fellowship and is a professor of medicine, infectious diseases, and epidemiology. She serves in a variety of roles at Yale New Haven Hospital, including hospital epidemiology and emergency preparedness, prior to joining the VA Connecticut healthcare system in 2016, where she is the hospital epidemiologist. And we have Dr. Russi, who's a professor of medicine and epidemiology at Yale and the medical director of wellness and employee health for the Yale New Haven health system. He is active nationally on issues of healthcare worker safety and has authored a number of guidance documents and currently serves on 2 federal advisory committees. So we're going to have Dr. Dembry present first, and then Dr. Russi will present.
Good morning, everyone. We're going to talk about bloodborne pathogens. I'm going to start out and I'm going to talk about what they are and some of the things around the epidemiology and how to protect yourself. Next slide, please, Sheila. So you're here because annual training is required by OSHA every year, and it's also a good time to remind people about some of the safety things that they can do and take control of their own safety at work. Next slide, please. Okay, so bloodborne pathogens. Generally, we think about what I call the big 3, hepatitis B, hepatitis C, and HIV, with hepatitis C being the most prevalent. But it's important to remember that there's a variety of other bloodborne pathogens as well. There's a list of over 20. I've only listed a few of them here. So this is generally about how to protect yourself overall from bloodborne pathogen exposures while you're at work. Next slide, please. So how are bloodborne pathogens transmitted in the healthcare setting? The one we're going to talk about this morning is percutaneous transmission, but you can also have a mucosal exposure to blood or body fluids from infected patients, and that's usually through a splash or a spray. Splatter to the face, or direct inoculation of the virus into non-intact skin. So that could be if you have a cut or a burn or some kind of skin lesions and you come in direct contact with blood or body fluids, you could have transmission of a bloodborne pathogen. Next slide, please. So the risk of infection for percutaneous injuries varies with the pathogen that's involved, the type of exposure that you have, the amount of blood involved in the exposure, and the amount of virus in the patient's blood at the time of exposure. So all these things come into play should you have an exposure and what your risk is. Next slide, please. So for percutaneous injuries, we're talking about generally needles and sharps, and most of the injuries occur during the use of the item. And that's about half of them. But there's also about 12 or 13% occur between steps of a multi-step process, or after use before disposable, that's about 10% of them. So during use, between steps in a multi-step process and after use before disposal, that makes up about 75% of all of the injuries. And you can see there in the pie chart that there's a variety of others included. And then there's a whole kind of basket category of other, which makes up 13%. Next slide, please. When we talk about the devices associated with percutaneous injuries, most of them are in the category of other, which is a variety, and close behind that is suture needles, which makes up 26%. So the OR is a place where there are a lot of opportunities for sharps injuries, and that's where the vast majority of sharps injuries occur, as well as in the emergency department. And also other types of injuries from disposable syringes, essentially that's about 25%. That used to be the one we thought of as more common, but there are many more safety devices now, and so that has gone down. And then you can see down in the bottom corner there at about the gray area where the scalpel is about 5%. Next slide, please. So when you look at the pattern of needle sticks and sharps injuries, this was from a study that was done not that long ago, and looking at hands, where did people essentially get stuck? And the vast majority were on the index finger and the third finger of the left hand. And you can see that the ring finger of the left hand had very, very few injuries associated with it. Next slide, please. So I commented on most sharps injuries, or many of them occur in the OR, usually with sharp tipped suture needles causes most of those injuries. And that's usually about half of those are at the time of suturing muscle and fascia. 78% or so will be related to devices that didn't have a safety feature, or a device with a safety feature was available what wasn't used. And the exposure in the OR is generally surgeons, as you can imagine. They're the ones who have the most contact with sharps and are using them. But there's other personnel as well who can sustain a sharps injury. And sometimes that's in passing a sharp and disposing of a sharp, cleaning up after a case, a variety of other reasons. But as you see there, about half of them are in surgeons. Next slide, please. So this was a study, and I think I've presented this here before, but I like to go over it again because I think there's some important things. So this was a study that looked back 10 years. It was a cohort study at a single academic surgery center where they looked at 333,000 surgical procedures, and there were a little over 2,000 bloodborne pathogen fluid exposures that were analyzed. And overall, they found that the exposures were about 6.3 per 1,000 surgical procedures. But what was interesting is it increased as there was an increase in estimated patient blood loss, and the number of personnel working in the surgical field, particularly when it was 15 or higher, the risk of injury went up, as well as the duration of the procedure. The longer the procedure, the higher the risk. And looking at regression results show there was an association with strongest for suture needle related exposures. Next slide. As I said, about half of them were from suture needles. And when you look at the occupational group, the attending physicians made up a little more than a quarter, but fellows, residents, and students were at about 40% of them. Next slide. This is another study where they were looking at whether there were any changes on needle stick injury prevalence after 2003. And there was a new addition to the bloodborne pathogen standard in 2001 that required safety devices. And so that's why they chose 2003. And they looked at medical students and other Department of Surgery staff. And of those, about 38 or 39% had reported that they'd had a needle stick injury, and 2/3 of those had occurred in the OR, and 11% were high risk. They defined high risk in this study as hepatitis B, hepatitis C, or HIV infected patient. Next slide. And when they asked, if this was a survey, so when they asked, if you had an injury, why were your reasons that you thought you had the injury? And about half said that basically it was accidental, or they were being careless, and put that in quotes because those are the words that they used. And 20% felt that they were rushed. But almost there you can see 29% reported being stuck by another individual. And that's where the OR becomes a pretty unique environment where there's a lot of sharps and many individuals. And so it's not always the user of the sharps that gets injured, it can be somebody else. And about 1/3 had reported at least one, had said that they had at least one unreported needle stick injury, and it didn't differ by position. And this has been pretty standard over time. You will see there are estimates that about half of needle stick injuries or sharps injuries are not reported, and they tend to be higher among surgical personnel as far as not reporting. Next slide, please. They also asked in this survey which of the 3 bloodborne pathogens, which we're focusing on today, were most of a concern to them, as well as did they know what the incident of that bloodborne pathogen was. And as you can see, looking over to the right, many of them answered, I don't know. But I think what's interesting too, there on the left, the first bar, is that many of them believe the incidence was actually lower than it really is. Next slide. So they also asked them about their prevention practices. About 79% said that they always double glove. That was highest for medical students and then lower for fellows. They didn't double glove. One of the more common reasons said that they didn't feel that there was a need. This was a change that from what had been seen before about a decade earlier, where individuals said, well, they didn't have like the same tactile feel. And so the thought with this was, well, people have gotten more used to double gloving, and that's all that they trained with. And so they didn't have as much of an issue with not having the same tactile sensation. but they started to make a decision like, based on this patient, I don't think that there's a risk, and so then I'm not going to double glove. Interestingly enough, 79% said they always wear eye protection. This is something that has generally been lower in in other studies that have done actual observations, and about 80% said they had gotten hepatitis B vaccine. Next slide, please. This was a study, and this was again another one that was from a survey, and this was looking at orthopedic surgery residents. I think I have a slide after this that shows a graph. Yes, I'll have you go to the next slide, please. So this was when they asked them how many had Sharp's injury during their time in training, and then with what type of device. The vast majority of them were solid needles. These are usually suture needles. And again, because these were orthopods, they had solid pins and wires, not as relevant, certainly in urology. Sharp tools or retractors, but still the vast majority of these were from suture needles. And then they looked at the respondents determined whether or not they would report a needle stick or Sharp's injury. It was higher if they knew the patient's infectious status. They also said the time to report the event. These were factors that affected reporting after an injury, how busy they were, what was the institutional call, and then also pressure from colleagues. And I'll show you in a minute another study where colleagues can be helpful in encouraging people to report needle stick injuries or Sharp's injuries. Next slide, please. This is another study. This was with plastic and reconstructive surgery. What I like with this is they really kind of break down into categories, predisposing factors for Sharp's injuries in the operating room. So there are physician factors, and some of these we can control and some not so much, but these are the ones that are more generally under your control. Instrument factors, lack of safety devices or the failure of a safety device, the type of instrument, the type of needle. And then there's the environmental factors, which are we talking about an urgent emergent case versus a routine scheduled case? How stable is the patient? How long is the procedure? And when the procedure was done, what time of day? Next slide, please. So these were the preventive strategies. Again, these break these down into various categories. And so we can look at Sharp's alternatives, look at safety devices, setting up neutral zones, double gloving, and then also protective facial wear. Essentially, we're talking about eye protection. So this was for all hazards, as far as these weren't just percutaneous, included also splashes to the face. Next slide, please. So the OSHA Bloodborne Pathogen Standard was essentially developed or in law in 1991. It has 4 areas that we have to address: administrative controls, and so that's really the policies and procedures, the exposure control plan, engineering controls, which are control measures that will isolate or remove a hazard from the workplace. So these are like your safety devices. Work practice controls, an example of that would be to not recap needles, and then personal protective equipment, which I'm going to take just a few minutes and talk about. Next slide, please. So standard precautions, it used to be called universal precautions. The term changed in 1995 because universal precautions essentially meant you applied these precautions when you were going to have potential contact with blood or bloody body fluids, but we recognize that body fluids don't have to be bloody for them to be able to transmit bloodborne pathogens. So in 1995, the term was changed to standard precautions, and it's contact with blood or body fluids, regardless of whether it's bloody or not, and used again in the care of all patients, regardless of their presumed infectious status. So one shouldn't assume that somebody is not HIV negative just based on their epidemiology or their age. When it comes to hepatitis C, actually in the baby boomer cohort, so now getting into the kind of later middle age, older group, is the one that has one of the highest prevalences of hepatitis C. So don't make assumptions about patients, and you want to apply these precautions to all patients. Next slide, please. So elements of standard precautions, the first one is hand hygiene. I'm going to talk a little bit about, then after that, the other PPE. Next slide, please. So hand hygiene, very important as part of standard precautions. I tried to break this down into sort of the activities that I call before and then after. So before touching a patient, before putting on gloves, before doing invasive procedures, before handling clean equipment or supplies, because you don't want to contaminate that. And then there's a between, which is between body sites. So this would be like examining a patient and they have an infected wound, and then you're going to examine some other part of them or a clean wound. You want to change gloves between going, say, from an infected site to a clean site. After touching a patient, after touching the environment around the patient or having their contact with that, after handling dirty equipment or supplies, and then what I call the personal activities before eating or drinking or after using the restroom. Next slide, please. So hand hygiene, just always want to put a plug in for this every year. I know people, say they know how to do hand hygiene. We still kind of fall down on this and our compliance is not what it could be. But just remember, if you're going to use soap and water, should do this for 15 to 20 seconds, making sure that you cover the thumbs, all the areas in between fingers and under nails, and not just rubbing the palms together. Next slide, please. I think you're all familiar now with alcohol-based hand rub. Makes it a lot easier to do hand hygiene pretty much anywhere. Finding a sink sometimes is not the easiest thing, particularly in older parts of hospitals that were not designed to promote hand hygiene. And so this becomes a challenge. So alcohol-based hand rub, it doesn't have to be Purell. Wherever you practice, they may have a different one. Certainly has made it a lot easier to comply. Next slide, please. So these are the areas you'd want to make sure you don't miss when you do hand hygiene. As I said, the thumbs between the fingers, fingertips, and then the wrists. Next slide. There are some times when you shouldn't use alcohol-based hand rub. In this case, I comment on Purell because that's what we use at Yale New Haven and also VA Connecticut. That's when your hands are visibly dirty, or if you had direct contact with blood or body fluid. So say, for example, that your glove tore when you took it off and you got blood on your hand, then you should use soap and water and not alcohol-based hand rub to do hand hygiene. Next slide, please. And another time is after contact with a patient who has C. difficile, should use soap and water to wash the potential spores off your hands. Next slide. Okay, next slide. Personal protective equipment. Here, this is a major component of standard precautions along with hand hygiene, and the goal is to protect the skin and mucous membranes from exposure to infectious materials that may spray or spatter. An important thing is make sure to remove this personal protective equipment before you leave treatment area. So some of the comments I'm going to make today in the time of COVID-19 are a little bit different, but I just want to remind people what you should be doing for standard precautions. Next slide, please. So gloves, you want to wear gloves when you anticipate potential contact with blood, saliva, or mucous membranes. So this is where you need to be thinking ahead of time about what you're going to do. Removing gloves after patient care, do hand hygiene. And if you put on gloves and they tear during the time that you're using, and you should remove them, do hand hygiene, and put on another pair of gloves. They're not a substitute for hand hygiene. Next slide, please. Gowns, masks, protective eyewear, and face shields. So gowns, this is where we kind of fall down a little bit. Gowns need to be worn to protect yourself and your clothing from blood or body fluids. And this is when you anticipate that you could have direct contact or it could be sprayed onto you. And make sure that you tie the gown at the neck and the waist so it doesn't fall down on your shoulders. What I have here about wearing a surgical mask, I mean, this is a little different because we're in the time of COVID where we're doing universal masking, but also eye protection. Think about that. If you could have spray or splatter to your face, then you should make sure you have eye protection. Next slide. Regulated medical waste, this is important. Make sure that you dispose of sharps in the appropriate needle disposal containers. They all have a line there. I put a yellow circle around it. It's called a fill line. If it looks like that the container is more full than what's the fill line, or at the fill line, don't put something else in there because that could potentially injure you. But otherwise, anything that's visibly dripping waste blood. So every state has somewhat different regulations about what they define as medical waste. In the state of Connecticut, if you have, say, something that is saturated, and just think of if you were to squeeze it, not something you want to do, but you could get a drop of blood out of it, then it's regulated medical waste. And it goes in red bag trash. However, if it's something where there's just like a little drop of blood on it after, say, drawing blood on a patient and it would dry, that's not regulated medical waste in the state of Connecticut. Next slide. So the Bloodborne Pathogen Standard was updated in 2000, November 2000, became effective in April of 2001. And it was meant to really push getting more engineering controls in place in healthcare and to try to decrease the number of sharps injuries and using more safety devices. Next slide, please. So preventable injuries, this is where we define these as where there's actually an alternative that exists that could eliminate the sharp device, or it could eliminate an unsafe feature of the device. But we also know that not all needles can be eliminated. And so needing to think about safety practices to prevent injury during those times when there's not a safety device that exists. Next slide, please. It was estimated that about 77% of sharps injuries could be prevented. And then this is what really pushed the update to the Bloodborne Pathogen Standard. Next slide. Ideally, a safety device would be integral to the device, something that works passively, that doesn't have to be actively engaged by the user, that the user can easily tell that the safety feature is activated, that something that can't be deactivated remains protective through disposal. Remember, even at disposal or just prior to disposal, some people can still have sharps injuries, so we want to protect that. And the device performs reliably and is easy to use and practical. So these are the kinds of principles around needle safety devices. When we look at options, what's available on the market, we want them as much as possible to meet these criteria. Next slide, please. So what's been the effect of this Needlestick Safety and Prevention Act? So this was a study that looked at percutaneous injury surveillance data prior to that time, essentially 1993 to 2006. That gave them some time also to implement the act. And at 87 hospitals, they looked at 31,000 sharps injuries. About 7,000 of those were to surgical personnel. What they found was that non-surgical settings, injury rates dropped by almost a third, by 31.6%. But in the surgical setting, the injury rates increased slightly by 6.5%. So essentially they stayed about the same, and still with almost half of these being suture needles. Next slide. Oh, and as also commented on the bottom there, most of them, 75% were also with passing of the device. So here we are 20 years later, or last November marked the 20th anniversary of the passage of the Needlestick Safety and Prevention Act, and we still have a lot of work to do. And so we're really trying to re-engage and really look at what we can do to get better about decreasing sharps injuries. Next slide. So this was a study, I think I've shown it to this group before, that I think is also interesting. And they looked at this, or anybody who's interested in kind of team dynamics and even high reliability organization principles. This is an interesting paper to look at. They looked at essentially the team, and did the team itself and how well they work together have a role in decreasing sharps injuries or the risk of sharps injuries. And so they have something that they call a social network measure. They refer to it in this paper as the Team Stability Index. And they use this to quantify the extent to which surgical team members work together. And they chose randomly about the previous 6 months. And they cite some literature about why they chose 6 months. It takes about that amount of time for people to get to know each other's practices, understand their communication style. So if they had worked together for 6 months, they had a high team stability index, 6 months or longer. So they found that this team stability index was associated with the risk of percutaneous injuries. And it was strongest for those injuries that involved devices other than suture needles. And so this is where they said, like, working together, like passing sharps, for example, they understood more how they communicated, what their style was. They had come together, the team would have decided how we're going to do things safely. And that seemed to have actually a significant effect on decreasing percutaneous injuries. Next slide, please. Next slide. That All right, so what can you do? So avoid use of needles where alternatives are available. I should put also sharps on there. And certainly if there are safety devices, we try to remove non-safety type similar devices so that there is no option for that. But get involved in selecting and evaluating safety devices. This is really important. The OSHA update in 2001 not only required healthcare facilities to be more aggressive about looking at and implementing safety devices, but also invite frontline staff in selecting and evaluating the safety devices. They're the ones who are going to be using them. So it becomes important that they feel comfortable with them and say that they will use them. Avoid recapping needles. I would even put there, don't recap needles. And plan the safe handling and disposal of sharps before any procedure. Dispose of the used needle devices promptly. You don't want them hanging around. We are responsible for all the sharps that we use. Report sharps related injuries promptly. So that is for your protection, and Dr. Russi is going to talk a lot about this, but it's also important so that the institution can understand where sharps injuries are happening, to whom, with what types of devices, and sometimes even we've had issues with some of the safety devices. And only by people reporting their injuries can we know what's going on and can try to address that and make the environment safer. And even if you have you feel there's a perceived hazard from sharps, or you observed one, even if there wasn't an injury, those things are important to report. And I just have here down at the bottom, obviously you have to do this training every year, follow the recommended infection prevention practices, which include standard precautions in the PPE. And if you haven't gotten hepatitis B vaccine and you are interested in that, you can, even if you declined in the past, you can still get hepatitis B vaccine. So encourage people to do that. Next slide, please. And as I said, that there is a push now to really, reinvigorate things around safety devices, decreasing percutaneous injuries. This is, 20 years after the update to the OSHA bloodborne pathogen standard. And so still see percutaneous injuries, and there's some data, I'm not going to show it here in the interest of time, that shows that there's been a slight uptick actually in injuries over the last 3 to 5 years. And so it's a really good time for us to redouble our efforts and look at this and what we can do to make things safer. Next slide. This is my last slide. So just remember, safety starts with you. It's with all of us, and infection prevention is everyone's responsibility. So thank you for your time, and I'm going to turn it over to Dr. Russi now.
So I'll talk a little bit more about background and prevention, talk about some of the recommendations of the American College of Surgeons, and then also discuss response to an exposure and how that should be managed. And assuming there's time at the end, touch briefly on transmissions in the other direction from a healthcare worker to a patient, and what are the expectations there. Next slide, please. And we'll, of course, talk a little bit about just the basis of post-exposure prophylaxis. Not a lot has changed there. Next slide. Next slide. So this is the the awful news and good news slide. And the awful news is that 58 healthcare workers contracted HIV from occupational exposures. The very good news is that in the past 20 years across the United States, with an estimated 5,000 to 15,000 needle sticks with HIV positive source patients, there has been only a single documented HIV seroconversion in a healthcare worker that actually occurred with exposure in a laboratory to concentrated virus. Probably the most important thing that has caused this substantial improvement is that by and large HIV positive patients are getting good care these days. Their viral loads are suppressed. But in addition to that, the threshold in US healthcare institutions for administering prophylaxis is low. And we do our best to err on the side of caution and at least begin prophylaxis if there may be a possibility of someone's having been exposed to an HIV positive source patient. And it's probable that prophylaxis as essentially the standard of care when a needle stick occurs with a suspected HIV positive patient, is also responsible for this decrease. You can see also that the transmissions that did occur in past years were principally percutaneous. There were some mucocutaneous as well, and that most of them occurred with blood rather than with another bodily fluid. Next slide, please. So the risk, the generally quoted risk of this based on those data prior to the widespread implementation of post-exposure prophylaxis was about 0.3% for percutaneous injuries, and a good bit less than that, as you can see, for mucocutaneous injuries. We do not think that there is risk from exposure to intact skin. Next slide. As Dr. Dembry mentioned, the changes around 2000 with the expectation that all hospitals need to be implementing safety devices have helped. However, we still have plenty of needle sticks, unfortunately, across the country. There have been a number of studies that have suggested that the safer devices have reduced needle sticks. There also have been a number of studies that have looked at the impact of use of blunt suture needles for certain aspects of surgical care, which have also demonstrated reductions in needle sticks. Next slide. I think that we have discussed this one in the past. I don't need to go into too much detail, but suffice to say that needle sticks are common, and they're common among surgical trainees. By the final year of training, 99% of residents had had at least one. Of note, when residents thought it was higher risk, they were more likely to have reported the injury, and about 80% of them, these injuries occurred with a solid needle. About half of them occurred during suturing. Next slide, please. You know, the trouble with a lot of the literature that addresses needle sticks, whether in the operating room or outside of the operating room, is that studies depend essentially on passive data. They give us lots of information about the needle sticks that people choose to report. There have been some studies, however, where direct observation has allowed us to get a better notion of just how many needle sticks are actually occurring. This was a Quebeman study many years ago that generated the fairly alarming statistic that in up to 15% of operations, a needle stick or a cut was occurring. Next slide, please. So one of the studies, and this was probably really about the best of them, that looked at blunt needles, used that technique, and they had a fairly lengthy run-in period where every single surgery was observed. These were done in departments of gynecologic surgery. So they were able to generate reliable numbers for how many needle sticks were actually occurring. And then what followed was the implementation of blunt needles. What they found was when they subjected that to logistic regression, that when 50% of the sutures used were blunt, that there was a reduction of nearly 90% in needle sticks. And on the next slide, you can see, next slide, please. The bar graphs actually show increasing use of the blunts. The line graph is the decreased rate of needle sticks. Next slide. So the American College of Surgeons actually issued a position statement supporting the universal adoption of blunt suture needles as the first choice for fascial suturing, and that they should be available in various sizes, and encouraged further investigation of this. Next slide. A couple of other ACS statements, the first one addressing double gloving, that this should be universally adopted. There has been pretty good adoption of double gloving by and large. Next slide. Hands-free technique is one where there isn't quite as good a consensus. These are the data from a study that suggested, at least in operations where there was more than 100 cc's of blood loss, that there was benefit of there being a neutral zone to which the surgeon passed and from which the surgeon picked up. The next slide. Actually looked at this and did not find that there was impact of the neutral zone. And so next slide. The ACS bottom line here was that it recommended hands-free technique as an adjunctive safety measure to reduce Sharps injuries during surgery, except in situations where it may compromise the safe conduct of the operation, in which case a partial HFT can be used, meaning that the surgeon is handed the instrument, but hands the instrument off to a neutral zone. Next slide. Sharps substitution, of course, goes on not just outside of the operating room, but there are a number of substitutes that have come into common use over the years that likely reduce the risk of needle sticks, and some of those are listed here. Next slide. And of course, robotics. Next slide. So I'm going to talk a little bit about prophylaxis, which actually we're about 25 years into the time during which there has been an official U.S. Public Health Service recommendation for post-exposure prophylaxis. So I'll talk a little bit about what that's based on. Next slide. Next slide. So really the basis of this was a case control study. Denise Cardo, who is still at CDC, did this study. And she looked at, next slide, 33 healthcare workers who had had exposures to HIV positive source patients and who seroconverted. And she compared those healthcare workers to 679 individuals who also had been exposed to HIV positive patients, but had not seroconverted, and then looked at the differences in those groups. And not surprisingly, among those who had seroconverted, there was a higher proportion of some of the things we recognize as associated with higher risk, such as large gauge needles, deep injury, a device that's visibly bloody, a device where the instrument actually goes into a needle, the needle goes into an artery or a vein, and also terminal illness in the source patient. That is an index of higher viral load. And when she looked at post-exposure use of zidovudine, there was a higher proportion of individuals in the control group who had used that, but it wasn't a stunningly large result. However, on the next slide, you see that when controlling for some of those other risk factors, that the odds ratio that was associated with post-exposure zidovudine use, which was really the only thing available in this particular, when this study was done, was associated with a 0.19 odds ratio, suggesting about an 80% reduction in risk. Next slide. Also some data from early study of administration to zidovudine to HIV positive pregnant women. This was a trial that was halted midway when it was shown that placebo moms transmitted HIV to the fetus 22% of the time versus 7% among moms who got drug. And the bearing that this was regarded as having on prophylaxis was that when they controlled for viral load, they found that at every level of viral load, drug versus placebo moms, there was still an effect in reducing HIV in the fetus. So it wasn't just that the viral load was being reduced with fewer variants to get into the fetal circulation. The suggestion was that drug being on board in the fetal circulation was preventing infection from taking place. Next slide. And there have been a number of animal studies that have been supportive as well. Next slide. We can skip this. Next slide. The bottom line on the time course is that with the current 4th generation assays, it is regarded that if an individual exposed to HIV does the follow-up and at 4 months is still negative, that the individual has not become infected and there's no need for further follow-up. Next slide. Unfortunately, there have been episodes of drug failure. A lot of this was early on when single agents were used. Some of it can be traced to use of agents to which the virus had resistance, but there are a couple of cases actually where the right drugs appear to have been given at the right time, but they still failed to protect the individual. Obviously, this is based on small tallies of individuals because there haven't been very many seroconversions. Next slide. And we can skip this. Next slide. This is a slide borrowed from Mike Kozal. It basically just demonstrates that we really should never be giving fewer than 3 drugs, that giving 3 drugs makes it extremely likely that the virus would develop a triple mutation that would allow it to escape all 3 of the drugs. And you can see from the 2 columns here under single mutations and double mutations that the likelihood of virus developing resistance is a good bit higher. This, of course, is the whole basis of the combination therapies that are used to treat HIV as well. Next slide. We may have just kind of click through those if you would, Sheila. Thanks. I think we won't go into specific toxicities of drugs. Suffice to say that the regimens given these days are much better tolerated than what used to be given. The standard regimen that we are giving for prophylaxis now is a combination of tenofovir alafenamide, emtricitabine, dolutegravir with a ritonavir boost. It's a regimen that can be given once a day, tends to be very well tolerated. It's a little different from the recommendation from the most recent iteration of the CDC Guidelines, which was 2013. There have been some developments since 2013, obviously, and what we are giving now as standard of care across the health system is regarded as a better regimen than the most recent recommendation from 2013. And we'll see how soon CDC updates that. There's been a fair amount of discussion of that recently. Next slide. Next slide. We don't have to go into detail about these. And the next slide. Next slide. Next slide. Next slide. Thanks. So obviously one of the important things is that treatment is given right away. The recommendation has always been within an hour or 2 of the exposure to at least have the conversation and consider whether prophylaxis is indicated. There is no particular scientific basis for an hour or 2. We know from animal studies that early rather than late works better. The decision of the working group was that this would communicate urgency, so at least to walk quickly rather than to necessarily run, but not to delay these to the next day. So we do have 24-hour coverage for this. When bloodborne pathogen, potential bloodborne pathogen exposures occur after hours or on weekends, you should go to the emergency department. They have all of our protocols, and they can begin prophylaxis if it's indicated there. Next slide. There are a number of opportunities in various Yale departments for exposure overseas and, of course, rotations overseas. When right now, of course, during COVID, we have not been doing a lot of this, but in prior years, I was meeting with 40 or 50 individuals a year, discussing with them risks, and when they went into sites in the developing world, providing them with an initial packet of prophylaxis and setting up arrangements to continue that prophylaxis if they actually had a needle stick exposure. We also provided N95 respirators to those folks for TB protection. In the coming months, I would expect that we'll begin those offsite rotations. Again, how soon, I'm not sure. Certainly we're not doing them right now, but over the course of the next year, if you have an opportunity to travel, particularly to sites in the developing world where HIV prophylaxis might not otherwise be immediately available, please set up something with me so that we can discuss that, and then I can provide prophylaxis for you to take with you. Next slide, please. So hepatitis C, obviously there has been wonderful developments in treatment of hepatitis C in recent years. This is essentially a curable disease these days. And there has been some recent change in the guidance around hepatitis C exposure for healthcare workers. Next slide. As all of us know, this is the hepatitis that has great propensity to cause a chronic disease, and frequently, in addition to that, does not declare itself right away. So many people who become infected with hepatitis C don't immediately manifest symptoms. Next slide. And just some information here. Essentially, CDC updated guidance several years ago recommending that source patient testing should be done with PCR rather than with antibody, and that healthcare antibody testing should be done at the time of exposure. And that a healthcare PCR at 3 weeks could be regarded as evidence that transmission had not taken place. Next slide. There was some pushback on that, not really based on a lot of data, actually, but based more on the inclination to err on the side of caution. And the decision was made actually to update that guidance. So last year there was published an update to that guidance that in addition to the PCR test at 3 to 6 weeks, that a test should be done at 4 to 6 months to be certain that HCV seroconversion did not take place. And one of the reasons for that is that there can be sort of waxing and waning viral levels, and it was felt that an antibody and PCR test at 4 to 6 months was a good and reasonable precaution to take. Next slide. I think we'll skip this one. Next slide. So the approach to HCV exposure these days is, of course, different from HIV exposure, and that's because the therapy, which is pretty involved, is potentially nearly 100% effective. And the thinking is that it does not make sense to give prophylactic therapy and end up treating potentially hundreds of people for the one person who might otherwise be infected. When there are drugs that can actually be given to that individual, should that individual seroconvert, and a near 100% likelihood of curing the individual from that infection. And so that's the reason that we manage HIV with prophylactic therapy, and that we manage HCV with close follow-up, and then immediate institution of the direct-acting antiviral therapies, which are very effective in order to clear the person of virus. Next slide, please. So other bloodborne pathogen issues with respect to hepatitis B, the most important thing, of course, is to receive the hepatitis B vaccine. Nearly all people who get that vaccine respond to it, but some don't. The recommendation from CDC for healthcare workers is to get 3 doses of vaccine, check a surface antibody. If the surface antibody is negative still, to repeat the entire series, check it again. If it's still negative, to double check to make sure there isn't chronic infection that can cause lack of response to the vaccine. And if surface antigen is negative, basically regard the individual as a vaccine non-responder and make certain that the individual understands that he or she will need to have hepatitis B immune globulin should an exposure occur. We don't have a lot of people who require that, but we do have some. There is a newer hepatitis B vaccine that came out a couple of years ago. The response rates are a little bit higher to that. And so one alternative there in non-responders is to try that adjunct vaccine. And probably worth seeing if there's response to that rather than throwing in the towel and just regarding someone as a non-responder. The next issue, and I think we do have time for this, is just to touch base briefly on infections in the other direction. Fortunately, they don't happen very frequently, but it's important for all of us to understand what the expectations are of us around that. Next slide. Next slide, please. So there have been, as you can see, a number of instances of transmission of hepatitis B. A lot of this occurred prior to universal precautions and prior to prior to standard precautions as well. And you can see occurred during a number of different types of surgical procedures, and nearly all of these were linked with E antigen positive providers, E antigenemia, basically a marker of much, much higher levels of viral replication. Next slide. Fewer instances of hepatitis C transmission, but a number of them have actually been documented. And in the past 10 years, there have even been a couple of hepatitis C transmissions, a couple of hepatitis B as well in the last 10 years. And next slide, please, Sheila. With HIV, in 25 years of follow-up, there have essentially been 4 instances of transmission. And the first of these was a cluster that no one quite understands adequately, but there is some concern that this HIV-infected Florida dentist may have transmitted with quite substantial lapses in normal technique. One of the most discussed cases was one which occurred in France, where an orthopedic surgeon, not knowing he was HIV positive, transmitted HIV to an elderly patient during a lengthy hip replacement procedure. There is an episode of transmission from a French nurse, which no one understands very well. It was not obviously something that occurred during surgical procedures. And then there is a transmission that occurred with a Spanish obstetrician gynecologist. That's really it. Clearly, the risk is extremely low, but it's certainly an event that we want never to happen. Next slide. There have been a number of look-back studies, patients who underwent surgical procedures with HIV-positive surgeons, and those have not shown additional cases. Next slide. There have been a number of SHEA guidelines around the Society for Healthcare Epidemiology of America, first in 1991, and then in 97, and then in 2010, and most recently last year. And really, SHEA has taken the lead in this particular area. There's CDC guidance from early on that was fairly perfunctory. A number of other professional societies have looked at this as well. And Dr. Dembry, by the way, has been quite involved in this work. But the current standard is that for hepatitis B, when the viral burden is greater than 1,000 international units, that individuals should not be carrying out surgeries if the viral burden is greater than that. The standard, and I've worded this awkwardly, I apologize, the standard for HCV is that essentially it should be undetectable in order for individuals to continue to carry out surgical procedures. And in cases where it's not possible for individuals to have undetectable viral loads, to tolerate up to a load of 2,000 international units. The standard to continue to carry out surgeries for HIV is that the load should be under 200. Category 3 procedures basically are surgical procedures. The other expectations that go along with it are double gloving. Next slide, please. And the standard is that procedures are permissible if the viral burden is less than those levels, again, for Hep B, less than 1,000, for Hep C, undetectable, and for HIV, less than 200, and that the individual has not been detected to have transmitted, that an expert advisory panel has advised regarding any change in surgical practice that's necessary, that there's routine follow-up to make sure that the viral burden continues to be managed adequately, that the individual remains in treatment for disease, and that an infection control expert is consulted regarding the case. One of the expectations, of course, is that if an event occurred during a surgery, if a slice to the finger, for example, where an HIV positive or HB or HCV positive surgeon bled into the field, that the patient would actually need to be notified of that so that the patient could receive prophylaxis with HIV, could get appropriate follow-up for HCV with treatment if seroconversion occurs, and anything that would need to be done around HBV. There is not an expectation that patients should be advised prior to a surgery that a member of the operative team harbors a bloodborne pathogen. Next slide, please. Next slide, please. I think that really concludes my remarks. Are there any questions on anything that either Dr. Dembry has discussed or that I've discussed? I think you guys have heard this stuff enough, frequently enough.
Are there any questions for our speakers? I think everyone is familiar with the topic, and we appreciate you presenting today.
Thank you.
Sure. Thanks so much. Have a good day.
Thanks very much. All right. Thank you. Have a good day.
Bye-bye.